Hi, I am Tanya Anand. Welcome to the second edition of Forks and Things, an initiative sponsored by the AAST Associate Member Education Committee, where we provide an overview of trauma algorithms, which may guide you in your practice. I would like to thank Dr. Bellal Joseph, Dr. Napreet Dillon, and Dr. Saskya Byerly for their instrumental support. We will be discussing the brain injury guidelines, or BIG, that are currently utilized to aid the trauma and acute care surgeon navigate the management of traumatically brain injured patients. These guidelines were published in the Journal of Trauma in April 2014 and were validated later that year. A AAST multi-institutional validation study involving over 2,000 trauma patients in 11 centers has recently been completed, and the results will be published in the Journal of Trauma. I'm joined by Dr. Bellal Joseph, creator of BIG. Dr. Joseph is the Division Chief of Trauma, Surgical Critical Care, Burns, and Acute Care Surgery at the University of Arizona. He is a Martin Gluck Endowed Professor of Surgery, Vice Chairman of Research, and the Associate Director of the Surgical Critical Care and Acute Care Surgery Fellowship. Thank you, Dr. Joseph, for taking the time to discuss BIG with us here today.
Thank you, Dr. Anand, and to the entire Associate Member Education Committee for this opportunity. As many of you know, the management of traumatic brain injury is multifolded and it involves multiple disciplines. When we started this about 10 years ago, we really set on this journey because about 90% of traumatic brain injury is managed non-operatively. And all that management occurs in the ICUs, the trauma bays, and the acute care surgeon is the one who's intimately involved in that care. And the resources to manage traumatic brain injury have been somewhat limited over time, which brings us to why we need to be at the forefront of this. Which brings us to Forks and Things. We will be discussing the when, the how, the who, and then the special considerations of how this will be applied in the future. Now, when we think about the who for the brain injury guidelines, these are all adult trauma patients who have a bleed or intracranial hemorrhage on their initial CT scan. You need to have a full history, neuro exam, which I think is the most important factor, and then the CT findings, which will help us with the classification of these patients. And when we look at BIG here, you can see the brain injury guidelines are divided into classification and therapeutic plan. When you think about the red box here, that's the classification. It's divided into 3 different parts: Big 1, Big 2, Big 3. And it's important to look at, some of it is exam, some of it is medication or alcohol use, and then the rest of it is the actual bleed and differentiating the bleed. The therapeutic plan is based on the need for hospitalizations, repeat head CT scans, and neurosurgical consultations. Big 1 is probably the simplest to understand. And remember, in order to meet any one of these classifications, you have to meet all of the criteria. So if you don't have all the criteria, that automatically puts patients at Big 3. The idea is to be safe. Big 1 is bleeds less than 4 millimeters, no skull fractures, and the neurological exam is completely normal. Subarachnoid is hard to measure, so it's actually based on whether it's trace, localized, or scattered. And if you have a Big 1 patient, they don't need to be hospitalized. They can be observed in the ED or trauma bay, and then no neurosurgical consultation, and then discharge. When you look at Big 3, that area is actually quite easy as well. These are the severely injured patients, greater than 8 millimeter bleeds, scattered subarachnoids. If you have multiple bleeds in different areas, that makes you a Big 3. These patients have abnormal neurological exams on exam and are on any anticoagulant. And these patients need to be admitted to the ICU, need a repeat head scan, and then again, need neurosurgical consultation. The Big 2 is Tiger Country, or the gray zone. These are the patients who have bleeds from 5 to 7 millimeters. I think it's important to note that they are not on any anticoagulants. The skull fracture is non-displaced. And again, these patients are admitted to the hospital. They are observed. They're getting the Q1 hour neuro checks. However, no mandatory repeat head CT or neurosurgical consultation. This brings us to the impact and the things. The impact really over the last 10 years, we've shown that implementing the brain injury guidelines in is safe in trauma centers. I think we've reduced the number of neurosurgical consultations, admissions, length of stay, ICU length of stay. And this is because the biggest impact BIG has had is on these Big 1 patients. The the data shows that, we've reduced a majority of the resources in Big 1 and Big 2, and the need for all the extra resources in Big 3 are still there over the years. The criteria are actually changing. There's a lot of discussion currently about how much of the anticoagulants actually need to be all Big 3. At our institution, baby aspirin is now a Big 1. We don't make it a Big 3, but this needs a little bit more work and data before we can move in that direction. As far as implementation, this has been implemented across multiple networks. Multiple states have implemented it into their regions. I think where you have sparse neurosurgical coverage, this is helping us kind of define a safe protocol forward. And the future directions really is taking big beyond the level 1 trauma centers into children, taking it into level 3 centers, level 4 centers. So all these big ones, that's where I think we need to start, aren't being transferred over. Again, I want to thank the entire AAST Associate Member Education Committee for the opportunity. Thank you, Dr. Anand, and good luck.
Thank you, Dr. Joseph.